We decided to do this study because the issue of pain after infection or a physically or psychologically traumatic event is a really hot topic in pain medicine now. A substantial proportion of patients experience pain during and after previous epidemics, including SARS, severe acute respiratory syndrome, MERS, Middle East respiratory syndrome, and H1N1, swine flu. We know that a substantial proportion of patients diagnosed with nociplastic pain conditions, which is pain characterized by central sensitization, including irritable bowel syndrome, fibromyalgia, and bladder pain syndrome, report a specific inciting event. My name is Stephen Cohen. I'm the Chief of Pain Medicine at Johns Hopkins Medical Institutions and the Director of Medical Research at Walter Reed National Military Medical Center.
Nigel Knox at Westchester Medical Center, Valhalla, New York.
Our study is entitled Pain Manifestations of COVID-19 and Their Association with Mortality, a multi-center prospective observational study. The authors are Nigel Knox from Westchester Medical Center, Chang-Soon Lee and Ji-Yoon Moon from Seoul National University, and myself. In some people, back pain from degenerative discs may have an infectious etiology. The biopsychosocial model of pain views physical symptoms as the denouement of a dynamic interaction among biological, psychological, and social factors. So not only the biological consequences of COVID-19, which can affect internal organs, joints, muscles, and the nervous system, but also the social and psychological effects can lead to short and long-term pain consequences. We performed this study at 3 hospitals with very different demographics. Johns Hopkins, a research institution located in inner city Baltimore, Westchester Medical Center, a teaching hospital located in the northern suburbs of New York City, and the main campus of Seoul National University, which is in downtown Seoul, Korea. We know that cultural differences can affect how pain is reported and treated, and that there may also be racial, ethnic, and socioeconomic differences in susceptibility to infection, disease severity, and even how patients are treated. When patients were admitted to the hospital, data was prospectively collected at Seoul National University and Westchester Medical Center on pain intensity, pain location, type of pain, and clinical characteristics, including pre-existing conditions, how pain was treated, and disposition, i.e. if they required admission to an ICU or they died. At Johns Hopkins, we prospectively collected data on patients with COVID for whom the pain management service was specifically consulted. Since the prevalence of pain is dependent on the means and rigor of surveillance, we hypothesized that a substantial proportion of patients would experience a variety of different pain complaints. We also hypothesized that pain might serve as a surrogate for viral burden or virulence, so that people with pain might be more likely to be admitted to the ICU and to expire.
In regards to pain prevalence, we found that a substantial portion of patients admitted for respiratory distress and other virus-related symptoms had a wide variety of pain presentations. At Seoul National University and Westchester Medical Center, 65 of the 169 patients admitted with active COVID-19 reported an active pain condition, with the most common complaints being headache and chest pain, 30% and 23.6% respectively. Other common pain complaints were spine pain, myalgia, abdominal or pelvic pain, and arthralgia. At the 3 hospitals, the patients were primarily treated with multimodal pharmacological approaches. Medication management was comprised of non-steroidal anti-inflammatory therapies or acetaminophen, 80%, opioids, approximately 18%, ketamine, 5%, and other adjuvants, not limited to muscle relaxants. We hypothesized that these individuals with significant pain will be more likely to experience adverse outcomes, including ICU admission and death. But when we controlled for age and gender, the opposite was found to be true. Among the patients reviewed, we saw an association between ICU admission, death, and the absence of pain. We could attribute these findings to both physiological and psychological factors. In regards to the psychological approach, for these individuals with life-threatening symptoms, the pain presentation may be distracted and of lower priority. Another aspect to review is the systemic stimulus associated with severe comorbidities, which may have inhibited pain signals secondary to catecholamine surges. which has been previously recognized in severe states, including severe respiratory distress and traumatic brain injuries.
So what are the main take-home messages for patients and clinicians? The chronic pain is very common during COVID. The pain can affect myriad organ systems and manifests in many different ways, and that we should embrace for a substantial proportion of patients to experience long-term pain sequelae even after they fully recover. And just today, I was reviewing an article that looked at patients who had muscle pain during COVID compared to a controlled cohort that did not. And 7 months later, those who had myalgias were considerably, significantly more likely to experience chronic pain at 7 months. We feel the future study should focus on determining the prevalence and types of chronic pain people with COVID suffer and should seek to identify early factors that may mitigate this. Thank you very much.
Thank you.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.